Neuroprosthetics is a discipline related to neuroscience and biomedical engineering concerned with developing neural prostheses. They are sometimes contrasted with a brain-computer interface, which connects the brain to a computer rather than a device meant to replace missing biological functionality. Neural prostheses are a series of devices that can substitute a motor, sensory or cognitive modality that might have been damaged as a result of an injury or a disease. Cochlear implants provide an example of such devices. These devices substitute the functions performed by the eardrum and stapes while simulating the frequency analysis performed in the cochlea. A microphone on an external unit gathers the sound and processes it. The processed signal is then transferred to an implanted unit that stimulates the auditory nerve through a microelectrode array. Through the replacement or augmentation of damaged sensors, these devices intend to improve the quality of life for those with disabilities. These implantable devices are also commonly used in animal experimentation as a tool to aid neuroscientists in developing a greater understanding of the brain and its functioning. By wirelessly monitoring the brain's electrical signals sent out by electrodes implanted in the subject's brain, the subject can be studied without the device affecting the results. Accurately probing and recording the electrical signals in the brain would help better understand the relationship among a local population of neurons that are responsible for a specific function. Neural implants are designed to be as small as possible in order to be minimally invasive, particularly in areas surrounding the brain, eyes or cochlea. These implants typically communicate with their prosthetic counterparts wirelessly. Additionally, power is currently received through wireless power transmission through the skin. The tissue surrounding the implant is usually highly sensitive to temperature rise, meaning that power consumption must be minimal in order to prevent tissue damage. The neuroprosthetic currently undergoing the most widespread use is the cochlear implant, with approximately 100,000 in use worldwide as of 2006. Update. History. The first known cochlear implant was created in 1957. Other milestones include the first motor prosthesis for foot drop in hemiplegia in 1961, the first auditory brainstem implant in 1977, and a peripheral nerve bridge implanted into the spinal cord of an adult rat in 1981. In 1988, the lumbar anterior root implant and functional electrical stimulation facilitated standing and walking, respectively, for a group of paraplegics. Regarding the development of electrodes implanted in the brain, an early difficulty was reliably locating the electrodes. Originally done by inserting the electrodes with needles and breaking off the needles at the desired depth. Recent systems utilize more advanced probes, such as those used in deep brain stimulation to alleviate the symptoms of Parkinson's disease. The problem with either approach is that the brain floats free in the skull while the probe does not, and relatively minor impacts, such as a low-speed car accident, are potentially damaging. Some researchers, such as Kendall Wise at the University of Michigan, have proposed tethering electrodes to be mounted on the exterior surface of the brain to the inner surface of the skull. However, even if successful, tethering would not resolve the problem in devices meant to be inserted deep into the brain, such as in the case of deep brain stimulation. Visual prosthetics. A visual prosthesis can create a sense of image by electrically stimulating neurons in the visual system. A camera would wirelessly transmit to an implant. The implant would map the image across an array of electrodes. The array of electrodes has to effectively stimulate 600-1000 locations. Stimulating these optic neurons in the retina thus will create an image. The stimulation can also be done anywhere along the optic signal's pathway. The optical nerve can be stimulated in order to create an image, or the visual cortex can be stimulated. Although clinical tests have proven most successful for retinal implants, A visual prosthesis system consists of an external imaging system which acquires and processes the video. Power and data will be transmitted to the implant wirelessly by the external unit. The implant uses the received power data to convert the digital data to an analog output which will be delivered to the nerve via micro-electrodes. Photoreceptors are the specialized neurons that convert photons into electrical signals. They are part of the retina, a multi-layer neural structure about 200 thick that lines the back of the eye. The processed signal is sent to the brain through the optical nerve. If any part of this pathway is damaged, blindness can occur. Blindness can result from damage to the optical pathway. This can happen as a result of accident or disease. The two most common retinal degenerative diseases that result in blindness secondary to photoreceptor loss is age-related macular degeneration and retinitis pigmentosa. The first clinical trial of a permanently implanted retinal prosthesis was a device with a passive microphotodiode array with 3,500 elements. This trial was implemented at Optobionics, Inc. in 2000. In 2002, Second Sight Medical Products, Inc. began a trial with a prototype retinal implant with 16 electrodes. The subjects were 6 individuals with bare light perception secondary to RP. The subjects demonstrated their ability to distinguish between 3 common objects at levels statistically above chance. An active subretinal device developed by Retinal Implant GmbH began clinical trials in 2006. An IC with 1500 microphotodiodes was implanted under the retina. The microphotodiodes served to modulate current pulses based on the amount of light incident on the photodiode. In 1968, Giles Brindley implanted an 80-electrode device on the visual cortical surface of a 52-year-old blind woman. As a result of the stimulation, the patient was able to see phosphenes in 40 different positions of the visual field. This experiment showed that an implanted electrical stimulator device could restore some degree of vision. Recent efforts in visual cortex prosthesis have evaluated efficacy of visual cortex stimulation in a non-human primate. In this experiment, after a training and mapping process, the monkey is able to perform the same visual saccade task with both light and electrical stimulation. The requirements for a high-resolution retinal prosthesis should follow from the needs and desires of blind individuals who will benefit from the device. Interactions with these patients indicate that mobility without a cane, face recognition and reading are the main necessary enabling capabilities. The results and implications of fully functional visual prostheses are exciting. However, the challenges are grave. In order for a good quality image to be mapped in the retina, a high number of microscale electrode arrays are needed. Also, the image quality is dependent on how much information can be sent over the wireless link. Also, this high amount of information must be received and processed by the implant without much power dissipation, which can damage the tissue. The size of the implant is also of great concern. Any implant would be preferred to be minimally invasive. With this new technology, several scientists, including Karen Moxon at Drexel, John Chapin at SUNY, and Miguel Nicolelis at Duke University, started research on the design of a sophisticated visual prosthesis. Other scientists have disagreed with the focus of their research, arguing that the basic research and design of the densely populated microscopic wire was not sophisticated enough to proceed. Auditory prosthetics, cochlear implants, auditory brainstem implants, and auditory midbrain implants are the 3 main categories for auditory prostheses. CI electrode arrays are implanted in the cochlea. AB electrode arrays stimulate the cochlear nucleus complex in the lower brainstem, and AMUS stimulates auditory neurons in the inferior colliculus. Cochlear implants have been very successful among these 3 categories. Today, the Advanced Bionics Corporation, the Cochlear Corporation and the Med-El Corporation are the major commercial providers of cochlear implants. In contrast to traditional hearing aids that amplify sound and send it through the external ear, cochlear implants acquire and process the sound and convert it into electrical energy for subsequent delivery to the auditory nerve. The microphone of the CI system receives sound from the external environment and sends it to processor. The processor digitizes the sound and filters it into separate frequency bands that are sent to the appropriate tonotonic region in the cochlea that approximately corresponds to those frequencies. In 1957, French researchers A. Journeau and C. Eries, with the help of D. Kayser, provided the first detailed description of directly stimulation the auditory nerve in a human subject. The individuals described hearing chirping sounds during simulation. In 1972, the first portable cochlear implant system in an adult was implanted at the Halcyon Clinic. The U.S. Food and Drug Administration formally approved the marketing of the House 3M cochlear implant in November 1984. Improved performance in cochlear implants not only depends on understanding the physical and biophysical limitations of implant stimulation but also on an understanding of the brain's pattern processing requirements. Modern signal processing represents the most important speech information while also providing the brain the pattern recognition information that it needs. Pattern recognition in the brain is more effective than algorithmic pre-processing at identifying important features in speech. A combination of engineering, signal processing, biophysics, and cognitive neuroscience was necessary to produce the right balance of technology to maximize the performance of auditory prosthesis. Cochlear implants have been also used to allow acquiring of spoken language development in congenitally deaf children, with remarkable success in early implantations. There have been about 80,000 children implanted worldwide. The concept of combining simultaneous electric-acoustic stimulation for the purposes of better hearing was first described by C. von Ilberg and J. Kiefer, from the Universitätsklinik Frankfurt, Germany, in 1999. That same year the first EAS patient was implanted. Since the early 2000s, FDA has been involved in a clinical trial of device termed the Hybrid by Cochlear Corporation. This trial is aimed at examining the usefulness of cochlear implantation in patients with residual low-frequency hearing. The hybrid utilizes a shorter electrode than the standard cochlear implant. Since the electrode is shorter, it stimulates the basal region of the cochlea and hence the high-frequency tonotopic region. In theory, these devices would benefit patients with significant low-frequency residual hearing who have lost perception in the speech frequency range, and hence have decreased discrimination scores. For producing sound, see speech synthesis. Prosthetics for pain relief. The SCS device has two main components, an electrode and a generator. The technical goal of SCS for neuropathic pain is to mask the area of a patient's pain with a stimulation-induced tingling, known as paresthesia. Because this overlap is necessary to achieve pain relief, paresthesia coverage depends upon which afferent nerves are stimulated. The most easily recruited by a dorsal midline electrode, close to the PL surface of spinal cord, and a large dorsal column afferents, which produce broad paresthesia covering segments caudally. In ancient times, the electrogenic fish was used as a shocker to subside pain. Healers had developed specific and detailed techniques to exploit the generative qualities of the fish to treat various types of pain, including headache. Because of the awkwardness of using a living shock generator, a fair level of skill was required to deliver the therapy to the target for the proper amount of time. Electroanalgesia was the first deliberate application of electricity. By the 19th century, most Western physicians were offering their patients electrotherapy delivered by portable generator. In the mid-1960s, however, three things converged to ensure the future of electrostimulation: Pacemaker technology, which had its start in 1950, became available. Melzack and Wall published their gate control theory of pain, which proposed that the transmission of pain could be blocked by stimulation of large afferent fibers. Pioneering physicians became interested in stimulating the nervous system to relieve patients from pain. The design options for electrodes include their size, shape, arrangement, number, and assignment of contacts and how the electrode is implanted. The design option for the pulse generator include the power source, target anatomic placement, location, current or voltage source, pulse rate, pulse width, and number of independent channels. Programming options are very numerous. The current devices use computerized equipment to find the best options for use. This reprogramming option compensates for postural changes, electrode migration, changes in pain location, and suboptimal electrode placement. Motor prosthetics. Devices which support the function of autonomous nervous system include the implant for bladder control. In the somatic nervous system, attempts to aid conscious control of movement include functional electrical stimulation and the lumbar anterior root. Stimulator. Bladder control implants where a spinal cord lesion leads to paraplegia. Patients have difficulty emptying their bladders and this can cause infection. From 1969 onwards, Brindley developed the Sacral Anterior Root Stimulator, with successful human trials from the early 1980s onwards. This device is implanted over the sacral anterior root ganglia of the spinal cord, controlled by an external transmitter. It delivers intermittent stimulation which improves bladder emptying. It also assists in defecation and enables male patients to have a sustained full erection. The related procedure of sacral nerve stimulation is for the control of incontinence in able-bodied patients. Motor prosthetics for conscious control of movement. Researchers are currently investigating and building motor neuroprosthetics that will help restore movement and the ability to communicate with the outside world to persons with motor disabilities such as tetraplegia or amyotrophic lateral sclerosis. To capture electrical signals from the brain, scientists have developed microelectrode arrays smaller than a square centimeter that can be implanted in the skull to record electrical activity, transducing recorded information through a thin cable. After decades of research in monkeys, neuroscientists have been able to decode neuronal signals into movements. Completing the translation, researchers have built interfaces that allow patients to move computer cursors, and they are beginning to build robotic limbs and exoskeletons that patients can control by thinking about movement. The technology behind motor neuroprostheses is still in its infancy. Investigators and study participants continue to experiment with different ways of using the prostheses. Having a patient think about clenching a fist, for example, produces a different result than having him or her think about tapping a finger. The filters used in the prostheses are also being fine-tuned, and in the future, doctors hope to create an implant capable of transmitting signals from inside the skull wirelessly, as opposed to through a cable. Preliminary clinical trials suggest that the devices are safe and that they have the potential to be effective. Some patients have worn the devices for over 2 years with few, if any, ill effects. Prior to these advancements, Philip Kennedy had an operable if somewhat primitive system which allowed an individual with paralysis to spell words by modulating their brain activity. Kennedy's device used 2 neurotrophic electrodes. The first was implanted in an intact motor cortical region and was used to move a cursor among the group of letters. The second was implanted in a different motor region and was used to indicate the selection. Developments continue in replacing lost arms with cybernetic replacements by using nerves normally connected to the pectoralis muscles. These arms allow a slightly limited range of motion, and reportedly are slated to feature sensors for detecting pressure and temperature. Dr. Todd Cookin at Northwestern University and Rehabilitation Institute of Chicago has developed a method called targeted reinnervation for an amputee to control motorized prosthetic devices and to regain sensory feedback. Sensory motor prosthetics. In 2002, an array of 100 electrodes was implanted directly into the median nerve fibers of the scientist Kevin Warwick. The recorded signals were used to control a robot arm developed by Warwick's colleague, Peter Kyberd, and was able to mimic the actions of Warwick's own arm. Additionally, a form of sensory feedback was provided via the implant by passing small electrical currents into the nerve. This caused a contraction of the first lumbrical muscle of the hand, and it was this movement that was perceived